Thanks for coming to our panel on the Affordable Care Act and hospitals and Medicaid expansion. My name is John Davidson. I'm the director of the Center for Healthcare Policy at the Texas Public Policy Foundation. And I'll keep my comments brief because I'm kind of losing my voice this morning, and I want to get to our panelists, and I want to have enough time for questions and for discussions afterward. This is quite a hot topic. Expansion was a major issue in the last legislative session. And recent news reports about Medicaid expansion alternatives being pursued in other states and the possibility of Medicaid expansion alternative or so-called alternatives being pursued in Texas has sort of reignited the issue and put it back into the public eye. We anticipate as a foundation Medicaid expansion being a major issue in the upcoming legislative session. We anticipate that a lot of the same arguments that we heard in 2013 will come out in 2015, but perhaps with more nuance this time, perhaps with more sophistication, and perhaps with more granularity of detail, which is where we hope this discussion today goes. We have a handout of a recent paper that I did, as well as an op-ed in yesterday's Austin American Statesman from our President Brooke on the issue of Medicaid expansion and some of the Medicaid expansion alternatives that we've seen in other states over the past year. Now, the reason it's an issue is obvious. Texas has the highest uninsured rate in the nation. Medicaid expansion promises that up to 1.5 million people could possibly get covered through Medicaid expansion, and so it's understandable that this is a question that a lot of people are interested in. A lot of providers and hospitals are interested in this as well as Texas taxpayers who have a stake in this policy question as well. The advantages, or the advocates of Medicaid expansion, claim it would reduce uncompensated care that Texas hospitals currently give to the uninsured, which numbers in the billions of dollars every year. That would increase jobs across Texas, increasing employment, particularly in the healthcare sector, and that overall Medicaid expansion would be an economic boon for the state, lowering property taxes that we now use to pay for uncompensated care. The opponents of Medicaid expansion, among them on the record many times is the Texas Public Policy Foundation, argue that in states that have expanded, we haven't seen the increase in jobs or boost in employment in the healthcare sector as predicted. And a number of studies are coming out now that are looking at the past year of states that expanded Medicaid and states that didn't expand Medicaid. Opponents of expansion also argue that ER costs increase as Medicaid expands, and that patients on Medicaid are more likely to access services through the ER than those who are not on Medicaid. And then, of course, overall Medicaid costs increase for the states that expand. Texas currently spends about $58 billion, or this biennium we will spend about $58 billion on our Medicaid program. That's about 30% of the all funds budget, especially if HHSC actually does get its $2.5 billion legislative appropriations request that put in to the legislature. And we'll delve into the pros and the cons, and we'll delve into some of these alternatives and what what's at stake in accepting the federal Medicaid expansion money. But I'm going to let the panelists do that, and as I said, try to get as quickly as possible to their presentations and then to a discussion and question and answer period. I'm going to introduce each one of our panelists one after the other, and then ask them to come up one after the other as well. Immediately to my right is Dr. Byron Schlomach, who's the chief economist at the Goldwater Institute in Phoenix, Arizona. He has 20 years of experience working in and around state government, including as chief of staff for a member of the Texas House and a researcher in the Office of Texas Comptroller. Formerly, he was the chief economist here at the Texas Public Policy Foundation, now, as I mentioned, at the Goldwater Institute in Arizona. He's advocated for transparency in hospital pricing and helped pass price transparency legislation in Arizona. He holds a PhD in economics from Texas A&M University. At the end of the table is Freddie Warner, system executive in public policy and government relations at Memorial Hermann Healthcare System. He joined Memorial Hermann in 2008. Prior to that role, he spent 20 years as a campaign and policy advisor to members of the Texas Congressional Delegation, the Texas Senate, Lieutenant Governor's Office, and worked as an independent consultant on legislative and regulatory projects or regulatory affairs for clients in D.C. and other states. He managed industrial development projects, investment and strategic plans, media and communication strategies for a wide variety of industries throughout his long career. And in the middle of the table here, we have Ted Shaw, President and CEO of the Texas Hospital Association. He joined the THA as its fourth president in February of 2014. Prior to joining the THA, he had a 40-year career in healthcare leadership, served as interim executive vice president and chief financial officer for Parkland Health and Hospital System in Dallas, and has worked for hospital systems in Miami, Louisiana, Vermont, Phoenix, as well as a number of healthcare technology companies. Please join me in welcoming our panelists here this morning. And I'll ask Ted to come up here and speak to you first.
Good morning, and welcome to the opportunity to listen a little bit about the Texas Way. I'm going to this morning talk to you about what we believe is a solution for Texas, and Texas being with the influence that we have can do a lot more than other states in this environment in order to pull this off. So what I'd like to do is first talk about what the Texas Way is, what we're suggesting, and what it's not. So what we're suggesting is the Texas Way program. This is a private insurance program for low-wage working Texans. There's over 1.1 million Texans right now that fall into what's called the donut hole, that don't have any coverage. And they can't get coverage. They make too much for Medicaid, and they make too little to get on the federal exchange. What Texas Way program is needed and why is it needed? First of all, we talk about the ability to get these people covered. The second is already in this state, we spend $5.5 billion in costs a year in taking care of the uninsured, the uncompensated care in the state. That's not charges, it's not funny money, it's actual money cost that's reported to the HHSC and audited on an annual basis. In order to cover that $5.5 million, as many of you who have your own businesses or whatever, when you have a cost, you have to have it covered somehow. And so what happens in the state of Texas is some of it gets covered through the 1115 waiver, and that's why that's so important. But that shortfall is about $2.5 billion a year. And by the end of the waiver period, that's going to be $4 billion a year. So what do you do to cover those $2.5 to $4 billion? Well, today, much of it's covered either through a cost shift to private insurance, where if you have private insurance, your premiums on an annual basis are about $1,800 higher a year in order to help the hospitals cover those costs. And if not, you're paying it in private property taxes, particularly in the large 6 or 7 hospital districts in the state. So we need to do something that addresses that, and because in any business you can't operate if you can't cover your costs. So as you can see, if we don't find a way to fund this and deal with this growing problem, we're going to see much more problems with regard to the health and viability of your hospitals in the state of Texas. The way that the healthcare system works today basically is if you don't have health insurance, you basically can't get in unless you're wealthy. You can't get in to see a doctor. You have to wait until you're so sick that you go to the emergency room. And so when you go to the emergency room, you're going to the most cost-intensive place in the entire healthcare system. So you're going to a very high-cost system. And even if you do get treated in that system, and hospitals have no choice. If you show up at their door, they have to see you. There's a law called EMTALA that says we have to, before we can even ask for financial credentials, we have to take care of the patient. So when you get and you work them through the emergency room, many times they get their medical issues immediately addressed, but then they're actually referred out into the community. Well, there's no community that's there to take them because they don't get paid well enough. A little bit off the subject here, but when you look at it pays hospitals about 52% of their costs, and it pays doctors and outpatients about 70% of costs. You can't make that one up on volume. You just continue to lose the more you see. So there's got to be a solution for this, and we believe the Texas way is it. So the Texas way is not Medicaid expansion. That's not what we're suggesting. The Texas way is not an open-ended entitlement to people. The Texas way is not a government handout, as sometimes it gets referred to. The Texas way is a responsible use of available federal funds. For the next several years, we can get 100% reimbursement, operating down to about a 10% covered, 90% 90-10 relationship as we go forward. If we can pull these federal fund dollars, and just basically Texas dollars, sitting in Washington back to take care of Texas, we can take care of this population at relatively low costs. We provide a private market solution so that people can get actually onto a private solution so they can have Blue Cross or another form of managed care opportunity. And it's in those environments where they can actually get insurance that they get access, because they get access to networks that have been developed by the private insurance companies, not trying to get access through Medicaid, which you know has got about a 19% acceptance in private primary care physicians at this point. So it's also a way that we can encourage them in terms of how we structure the program to get the consumers involved in their health care. How do we get them to be responsible? As opposed to waiting to go to the emergency room, how do we get them to access care? So we can do that in a number of ways. Part of that's going to be, and we'll go into some of the specifics here in a minute. And then also there's equity in here for your hospitals. The other thing is that as part of the original ACA, that got funded by significant cuts to hospitals. And as a result, when you didn't expand in Texas, when we didn't expand, all of those additional funds that were supposed to flow back to hospitals to cover those costs went away. So all of your Texas hospitals are experiencing and trying to live through those cuts in addition to the uncompensated care problems. So we've got to find a way to find some equity for your hospitals. This is particularly problematic when you look at not just the safety net hospitals, which are suffering. I mean, I think you'll hear some of the things that are happening in the state in the next couple of years with the safety nets are at risk, but particularly our small and rural hospitals that their margins are so thin without the ability to receive some of these Medicaid funds and pull them down through the Texas way. It continues to put them at risk, and I think you'll see many of them. We already had 4 hospitals in the state closed this year, so we want to avoid that. And the opportunity for Texas to let's create something that's real unique. Let's create something that's the Texas way so that we can design it. And I think that's what you'll find. I'm real proud to be a Texan. I love to go around the country and talk about the fact that we're the greatest state. We've got the best job creation. We've got the lowest unemployment in the country. And then I turn to the fact that we have 25% of our population that's uninsured. 1,000 people, over 1,000 people a day coming to Texas. That's great. Unfortunately, they don't arrive with insurance. And there's at least 25% of them as we find more people, because we haven't been able to put a dent in that 25% uninsured population in this last 2 years. So we've got to find a way to do that. How do we as Texas lead to be able to find a way to get these 1.1 million people, uninsured people, that are working Texas? These are not people that are looking in for a handout. These are people that are actually hardworking Texans, sometimes working 2 and 3 jobs. They just can't get coverage because most employers, small employers, don't provide that insurance. So let's find a way to do it. Let's find a way to make it work for them. Small businesses are most unlikely, and so one of the ways that we can provide by taking the federal funds and using them appropriately, either in premium assistance for the individuals, or in my discussions with CMS, they said they're interested in even allowing us to use some of those funds to provide employers incentives to provide health insurance through a health insurance program like the Texas way. So how that works and the details are or the devil's in the details, but we'll find that out. And then the Texas Payway program, again, will get to that 1.1 million working Texans and give them an opportunity to have health care like the rest of us, where they can actually access health care when they need it. We'll incentivize them to do the proper things. And one of the results is, yes, there's probably going to be a growth of some 60,000 jobs in the healthcare market. That's part of it. But when we get people treated properly and in the right fashion, they return to work quickly. They're not out of work. So you have a healthier workforce. Absenteeism is down. Workers' comp is down. Let's deal with it and get them appropriate. We get them healthy by indicating that they have to get annual mammograms, that they have to get annual checkups and things that'll keep them healthy. So one of the things that we suggest is the required use of health savings accounts, and seed these things with some of the federal money and allow them to grow with health savings accounts so they participate in their own health care and the cost of their health care. And this is one of the things that's worked in Indiana. They've had it for about 2.5 years now, and it seems to be working well. We can't, under the federal guidelines, we probably can't have the stick that says you got to have a job to get this. But we can do some things that are a little different than that, is provide incentives, maybe an additional funding for your health savings account if you do have a job. Encourage you to be working, or at least applying for a job. And then we can do some things like provide penalties and cost and charge people more when they inappropriately use the emergency room. And so that's one of the things that we would also build into this. And then, of course, we'd have some positive incentives for them doing those things, like having their annual mammogram, having an annual physical, getting a health checkup every year. And again, provide some incentives in the design of the health insurance program. Oops. There we go. And as a result, what will happen? There'll be a significant reduction in uncompensated care in the state. That $5.5 billion going to $4 billion. It'll be significantly reduced. Financial relief, I believe you can take the pressure off of the cost shifting. Once we've got these people covered and you've got the reduction in your uncompensated care, you can take some of the pressure off of the relief for cost shifting to private insurance, and certainly give some relief in terms of property insurance, in terms of the escalation of that. The thing to remember is we're already paying for this as citizens of Texas. It's how we're paying for it. Today we pay through property taxes. We pay for it through premium assistance in terms of private insurance. We need to find a way to share that burden and to take advantage of these funds to reduce that effect. And as a result, we'll have a more effective healthcare system. I've got 1 minute to go, so I'll talk to you about, and so we'd encourage you, there's more details if you would, a lot of discussion on our website about the Texas Way. I would encourage you to please join and get involved. We're interested in finding even the best ways. If we haven't found them, the only answers that right now, we're interested in getting the input to even find the better way. But we can do this the Texas way, and Texas is better than the other states, in my opinion. And we have some leverage with Washington to let us that we can make happen. So with that, I'll turn those. I guess my time is up. So thank you. Oh, great.
You don't need that. No, okay. Thank you very much. Well, thanks very much for the opportunity to be here to talk about the issue of coverage expansion in the state of Texas and some of the impacts of the Affordable Care Act. My name is Freddie Warner. I've been responsible for advocacy for the Memorial Hermann system for the last 6 years. And I want to begin my comments with kind of setting the table for what we see in Southeast Texas. We are the largest provider of care to the uninsured and Medicaid population in Southeast Texas. We've got a dozen hospitals, about 22,000 employees, and over a period of time, and I like to emphasize that a lot of the strategies of our system were employed well before the 2008 presidential election, well before Barack Obama was elected president, well before the Democratic-controlled Congress considered legislation that created the Affordable Care Act. We were looking at, from a system perspective, we were looking at the cost of health care delivery. We were looking at the fact that it is unsustainable going forward. If you look at it from a federal perspective, from a reimbursement perspective at the federal level or the state level, entirely unsustainable going forward. And our system, and a lot of what I would consider to be the forward-thinking systems across the country, didn't wait until 2009 or 10 to start figuring out how to bring down the cost of health care in their system. They were well ahead of that curve, looking at ways to bring down costs in their systems to gain efficiencies, et cetera. Where we are today, we're a $4 billion system. We've got the busiest level 1 trauma center in the country. We've got the busiest air ambulance service in the country. We've got the rehabilitation hospital treating the standalone rehab hospital that's treating the highest acuity patients among rehab patients across the country. We are sitting in the metropolitan area with the highest percentage of uninsured of any major metropolitan area in the country. And we're trying to figure out how to work within a set of fiscal dynamics, federal and state, that are not sustainable. And it's beyond the ability of individual hospital systems or, frankly, the hospital community on its own to solve these problems. So I want to put a finer point on a couple of these fiscal dynamics because I think, to be blunt, I think that for the last several years, anything that has to do with the Affordable Care Act, the ideological positions taken relative to it are fine. But the reality is it's considerably poisoned our advocacy when it comes to the opportunity to sit down with members of the state legislature and to sit down with members of Congress and talk about the reality, the actual impacts, whether those are the impacts of the Affordable Care Act on hospital systems or the impact of foregoing, call it whatever you want to call it, Medicaid expansion, coverage expansion, whatever it is. We looked at this with an eye towards the impact on our system of foregoing these dollars. However you might condition the receipt of those dollars going forward, fine. But for the purposes of our system and for a lot of the large nonprofit systems across the state, we are increasingly shouldering the burden of providing care for the uninsured and for the Medicaid population. My partner here in the room from the Harris County, the hospital district in Harris County, we are increasingly partners with our hospital districts in the major metropolitan areas. We live or die together. And if we can't figure out a way to infuse a healthcare delivery system for which the fiscal dynamics don't make any sense, that safety net's going to go away. And if you think we've got a problem now with hospitals closing, Ted referenced 4 closing, one of those is in our community. You think it's bad now? Wait till that happens. So a couple of things to think about. Federal and state reimbursement rates have been declining. Last year I gave 40 similar presentations, for the most part to non-healthcare communities, and talked about some things that most of the people in this room and a lot of people in healthcare have no reason to understand. So Ted referenced EMTALA. We have a federal law that was passed during Ronald Reagan's presidency that basically says if you show up at an ER, if there's an available bed, you have an obligation to treat and stabilize those folks. You can't ask them where they're from. You can't ask them if they're Republicans or Democrats, if they're rich or poor, if they're here legally or illegally. You got to take care of them. Okay? 65% of our admissions in our system come through the emergency department. And at the end of the day, I always say, if you hit the emergency department and you grab your chest, or you come in in an ambulance or on one of our Life Flight helicopters, you don't want them messing around. You want them to get to work, and that's what they do. But at the same time, this has created, for the last 30 years, the opportunity for folks to access and to abuse the emergency departments of hospitals across the country. That's a reality. And there's nothing that the hospitals today, there's nothing that we can do, and frankly, there's not much that the state legislature can do to stop that. That's just a reality that we have. Now, what are we trying to do about it? Okay, I believe we're the most highly integrated healthcare system in our state. We have tried to figure out where are the access points to the venues of the most expensive care we provide, and let's get people in those venues to figure out a way to navigate them out of there and put them to a place that is a much more appropriate venue for their care. We're doing a lot of this stuff. We're eating the cost of this stuff. I've got school-based health clinics across our system, a growing number of them, for which we cannot get Medicaid reimbursement. We're eating 100% of the cost of that. We're going to continue to do it because it's a good idea and it keeps those folks from overusing the emergency rooms in those schools' areas. We got navigators sitting in each of our ERs right now, and we're setting up primary care clinics, in some cases 50 paces down from the entrance of the emergency room, saying, come with us, we'll get you in here to see somebody. Hey, by the way, do you have Medicaid? Let us help you enroll for Medicaid. Are you aware that there's subsidies available for you under the Affordable Care Act? I mean, I've got folks who are basically de facto in the insurance business who are nurses and navigators, nurse practitioners, even physicians, doing whatever they can to help get everybody who's uninsured and using our system to get some kind of coverage. Why are we doing that? We got a $4 billion system. We gave away, if you want to look at it that way, we did $1.2 billion of charity care and bad debt last year. Each of the 3 fiscal years we just closed out as a system, we had increases of more than $100 million in charity care and bad debt. Not sustainable. To Ted's point, Medicaid-based reimbursement rates, we're at just over 50 cents. I always tell people, I use an illustration for non-healthcare audiences. Medicaid, you want to understand Medicaid? I make pins for a living. My plant cranks out these pins at $1 a piece. The most I can make in the marketplace is 50 cents when I sell my pin. How long am I going to be in the business of selling pins? You're not. That's Medicaid. Medicare, the same thing. You look at physicians right now, not my numbers, Texas Medical Association surveyed its membership across the state. How many of y'all would be willing, how many physicians would be willing to see a new Medicaid patient? 2012 survey figures, okay? 2000 survey figures, 67% of Texas physicians said they would see a new Medicaid patient. 2012, that number was 31%. Similar, not as bad a decline, but a similar decline occurred when you look at how many of them will see a new Medicare patient. So for the 1,000, the 1,500 folks a day who are fortunate enough to be coming to Texas, they expect not just good roads and clean air and clean water. They also want to have a good health care system. And we got to figure out a way to get more dollars into it in order to make that happen. So we're looking at base Medicaid rate reimbursements that have gone down. In the 6 years I've been in the system, they've gone down 11 cents, basically. So we go from 62 to 51 cents per dollar of cost of the care we provide. Base Medicare rates have gone down too. The Affordable Care Act, as Ted references, also bringing down Medicare rates. That's not sustainable. And you look at how you prop up the hospitals right now, as those in the private, the not-for-profit and the for-profit sector have agreed to step up and shoulder an increasing burden of the public hospital districts service, the care that they're providing to the uninsured and the Medicaid population. How do we do that? We've got the most complicated, if any of y'all saw Kevin Brady's Obamacare slide, it looks about like that when you look at the funds flow of federal, state, and local dollars to try to figure out a way for us to keep our doors open. The state only last legislative cycle, Kara Crawford is sitting over here, Tommy Williams and Jim Pitts agreed to infuse what we call our supplemental payment system, which basically puts some extra dollars into the system to try to prop up the nonprofit and the for-profit systems that don't have access to the property tax dollars that the public hospital districts do, to try to give us a bump above Medicaid rates. the state finally, for the first time, put some money into that. And representatives, I will tell you, we're going to come to you all this session and ask for the state to consider doing that again. Why are we going to do that? Because I think everybody in this room would probably agree that the prospects for coming up with another revenue source, if we were to say, call it a tax bill, y'all going to pass that this session? Likely not. So help us get through the next couple of years, at least the next biennium. And if we can't have an opportunity to take the federal dollars associated with coverage expansion, help us to continue the 1115 waiver that has succeeded at this point. And to the state lawmakers in the room, give us the opportunity, please support the opportunity to infuse our health delivery system with some more general revenue for the next biennium. I know we'll have an opportunity to explore some of these issues during the question and answer period. We've got a limited amount of time. I appreciate the opportunity to be here. I recognize that for those of y'all who do pay attention to the budget, I've been doing a lot of these conversations. We've had some conversations with State Representative John Otto, with John Zerwas, with Drew Darby in the room, and we talk about the fact that Article 2, for the first time in history, is going to surpass Article 3. That's a reality. We are not, by the way, in hospitals, we are not responsible for that. Okay? It's a reality, and it's unfortunate, and we wish there was a solution to it, but we're not responsible for that. The folks are going to continue to move to our state. The folks who don't have insurance right now are going to continue to work in our state. They're going to continue to get sick and get hurt. I'll throw a dirty word out there. We've got some undocumented who live in our state as well. Okay? Texas, among a handful of states, disproportionately high percentage of those folks. Guess what? They're working as well. They're getting sick, they're getting hurt. Guess what? They're showing up at our hospitals, and we got to take care of them. So I look forward to the questions and the opportunity to continue this conversation. We appreciate what the legislature attempted to accomplish. John Zerwas last session, Tommy Williams, Jim Pitts, and a number of members of the legislature. They were trying to come up with something that I think, if it appeals to your 10th Amendment sensibilities, created the opportunity for the state to come up with something that works best for the state of Texas. And we would hope y'all would have an open mind as we go into this legislative session. Thank you.
Well, I'm going to be the contrarian in the room today. If anybody's, I think Richard Vedder's already spoken in a previous panel, maybe yesterday. If you were there, I know I've heard a number of his speeches. He says, well, he can say anything he wants. He's got tenure. Well, right now I can say anything I want. I'm from Arizona. So, and believe me, I recognize the fact that being from Arizona, I kind of call pot calling the kettle black, I suppose, when I oppose Medicaid expansion, because we've expanded Medicaid. We had this governor that eats scorpions for breakfast or something, and somehow or another she missed her meal, and so that's what we've got. There are other issues about propositions. Don't ever adopt initiative. I've decided I used to want Texas to have initiative and as well as the referendum that we have for constitutional amendments. Don't ever adopt initiative. It's a terrible thing. When you talk about things like Medicaid expansion and the federal government's involvement in funding medical care and such, you hear remarks like this one from a Missouri state senator. You know, I don't like the law, but it's the world we live in. It's not the world I want to live in. I heard that same remark from some Blue Cross Blue Shield representatives in Arizona who wanted Arizona to create exchanges, Obamacare exchanges. And they said, hey, we want to we want something that's more free market than the federal government will ever do. And I ended up saying, no, the Goldwater Institute's never going to support something like that. And it was the same sort of thing. The new world that we live in is the Obama world, the Obamacare world. Well, you heard earlier something mentioned about the economic benefits of accepting the money. According to the Urban Institute, I couldn't find anything official, quickly anyway, about how much money might have come to the state of Texas with expansion. They estimated that beginning in 2013, Texas would take in $66 billion over a 10-year period. And I got to thinking about that. Well, I know it's going to be funded at 100% until 2016, then it ratchets down, and then demographics will carry it back up a little bit. But I just took a straight line average and said, okay, $6.6 billion in 2013. Usually what you hear is when people talk about the economic benefits of accepting money from the federal government, which is like manna from heaven, and it just drops on you like from a helicopter, they apply a multiplier to it. And they say, well, you know, this money will be spent, and then it'll be spent again, and spent again, and spent again, and a whole bunch of people will see a benefit from this, not just directly the hospitals and healthcare system. So they often apply a multiplier of about 3 to it. Now that's, I think, is a very, very generous multiplier. This is a highly optimistic view of what would happen with this money. And you get a $20 billion economic bump in a single year from all this Obamacare, Medicaid expansion spending. Isn't that wonderful? And I thought, well, what is that relative to Texas economy? It's a whopping 1.3% of GDP. That's after you apply an optimistic multiplier to the Medicaid money. So I would argue right off the bat, that it's not that big a deal economically. Now what I'm going to try to do is de-bamboozle you a little bit. It's a long quote. I'm not going to read the whole thing, but basically H.L. Mencken is saying here, in a nutshell, when you hear the same lie over and over again, you start to believe it. And then it becomes really hard to persuade people that it's a lie. And the world that we live in, it's one where the federal debt is crazy, $18 trillion, 100% of our GDP. Do you think Medicaid is being paid for by tax money? No, it's been being paid for by increasing the federal debt. And by the way, states are part of it. A third of the money that goes through states every year is from the federal government. In the biennium, the current biennium right now, Texas, 34% of the money flowing through the Texas state government is from the federal government. We're part of the problem, states are. And so that's the first thing I would point out is why not expand Medicaid? Well, because our federal debt problem is a whole lot bigger than our health care payment problem. And I'll talk more about that in a minute. It was mentioned earlier, well, we need to flow more dollars to the hospitals and everything. How much more do we need? For Pete's sake, we're up to 18% of the national GDP going into health care. And by the way, that's mostly because of health care prices. That red line there, that's a calculation I did a few years back. It's not updated for the most recent years. But if you took healthcare inflation down to general inflation, that's how much healthcare would take up of the economy. About half or less than it takes up right now. Medical inflation is way above general inflation. It's the prices that are the problem. And there was a recent an article in 2013 by Steve Brill. He just came out with a book. It's a whole lot of other stuff. His conclusions are totally erroneous, but many of the facts that he talks about are very, very pertinent. You know, the $1.50 aspirin, the $90 for a box of gauze, these kinds of outrageous charges that you see hospitals charging people. And he points out the fact that we always talk about who ought to pay for health care, but we never talk about why the prices are so blamed high. And then he points out, well, health care is unique in that improvements in technology actually increase costs, supposedly. In the history of mankind, any industry that you can think of, except for national defense, public education, and higher education, and health care, technology lowers prices, doesn't increase them. What do all these other four things have in common? Government interference and government funding. That's what they have in common. They're an opportunity. They turn technological improvement into an opportunity, not into a cost control measure. This is a chart I put together. A lot of people don't understand it. I'll apologize for that. But basically what it says is as we pay less and less of our own bills in healthcare costs have gone up precipitously. Why? Well, I had 2 babies on my own dime when I was in graduate school. That was back before they required you to have health insurance on the graduate students. When the docs asked my wife, I'd like to do a sonogram, she'd say, why? How much is it? And then no. When we had the 3rd baby, I was working for the comptroller's office. Thank you, taxpayers, you paid for my baby. He cost me about $20 out of my own pocket. When they said, hey, we'd like to do a sonogram. Sure, does it come in color? It makes a difference whether or not you pay for it yourself. So, what's the problem in healthcare? The problem is rising prices and the fact that third parties are paying for our bills. That includes insurance as well as the government. Third-party payers and expanding the third-party payer problem through Medicaid expansion is the problem. It's not the solution. Now, these are 2 economics papers I don't expect anybody in here to read, and I didn't read them in their entirety. But the fact is they're looking at what happens with Medicaid expansion. What can you expect in terms of labor supply effects? You give this new benefit at 138% of poverty, people get up to 138%, and then they're very hesitant to earn more money. They're very hesitant because their benefits drop off precipitously. And what that does is it puts people in job lock, job and career lock, income lock. And so what it does is it limits the labor supply and limits your economic growth. So that paltry 1.3% optimistic look at the impact on GDP that Medicaid expansion would have in Texas is actually mitigated and reduced by this impact. So that's my 3rd reason for saying don't expand Medicaid. It's going to have a negative labor impact and actually offset to a great extent that positive GDP effect that everybody talks about from getting the manna from heaven and going into debt more for our children and grandchildren. Then my question is, are hospitals really in need? Now, several years ago, I was looking at this situation. I'm looking at my own hospital bills. I've been to the emergency room for a few times. I've got 3 kids, 2 of them boys, and I've had my own issues. And not hard or anything. It's like trying to cut off a finger with a chainsaw, all that kind of stuff. You get these bills, and they just don't look like they have any relationship to reality. I mean, I took my kid in for a broken leg, and we got an x-ray and a splint so they could spend the weekend at home in pain before we could go to an orthopedist and actually get the leg set. And we got a hospital bill for $2,500, for Pete's sake. What for? My dad's a retired medical doctor. If we'd gone to him at an emergency room, we'd have walked out with a cast. But I might have been willing to pay for that. But anyway, you look around and look at hospitals. There are cranes outside every one of them, it seems like. They're constantly expanding. I'm an economist. I've taught economics. When I see that, I don't see an industry that's poor and in need. I'm seeing one that's expanding. That means there's a lot of profit there. Well, if I'm right, that's what their story looks like. And yes, that's a crane outside a hospital. Most hospitals, Memorial Hermann qualifies people up to 200% of poverty for charity care. Medicaid expansion will only cover up to 138%. It's the charity care that really matters here, not the bad debt. And you heard the number earlier, $1.2 billion in charity care and bad debt. The bad debt will not be impacted by Medicaid expansion. So I looked at it. Well, what is charity care compared to what these hospitals bring in? Well, it turns out you can find hospital financials on websites that show them their 990s, the nonprofit hospitals, Memorial Hermann being one. And since I knew a Memorial Hermann representative was going to be here, I thought, well, I'll look at Memorial Hermann.
That's
so
fair.
Sorry.
That's fair.
In Arizona, charity care represents on average about 2% of revenues, and this is program revenue. This is from patients. This isn't from contributions. Memorial Hermann, it's roughly about 4% of revenue. This Baylor University Medical Center in Dallas, it's about 4% of revenue. It did trend up the last couple of years in this chart, which is 2011, 2012. These are net revenues, revenue minus costs, for average in Arkansas and with several select Arizona hospitals. This is what they were the last several years at Memorial Hermann and Baylor University Medical Center. Memorial Hermann, Baylor almost makes as much in net revenue as Memorial Hermann on half the revenues. So that's something. And then Memorial Hermann manages to keep about a $400 million cash, while Baylor always reports less than $200,000. This is Memorial Hermann CEO's pay the last few years. Basically, since 2003, he's got a 21% annual increase, a bit above inflation. This is the annual lobbying that you nationwide on the part of healthcare areas. So my fourth issue is hospitals don't need the money. And these are some resources that you might want to read to talk about healthcare. My paper is an overall look at healthcare, and it's quicker than reading some of the books that are available that I reference. And just as a last remark, the thing about Medicaid expansion is that it's expanding government and healthcare, and we don't really need it. I have some other remarks about EMTALA and stuff that I could make, but I don't have time. But I did want to read a quick quote from Ludwig von Mises. He says, he points out, because government involves taxation, and there will be taxation in Texas to cover the Texas share of Medicaid expansion. Taxation, if you don't pay your taxes, it ends in violence because the government enforces its taxation edicts. And so what Mises points out is the essential feature of government is the enforcement of its decrees by beating, killing, and imprisoning. Those who are asking for more government interference are asking ultimately for more compulsion and less freedom. And the bottom line here is I don't have a problem with people making money, but don't make money off of compulsion on the part of government. Thank you.
Thank you to our panelists here. I want to get into a discussion and a question and answer time and give you all the opportunity to ask some questions. But as the moderator, I'll take the privilege to ask the first question to our panelists from the hospitals, Ted Shaw and Freddie Warner, and either one of you or both of you can answer this question. We talked about emergency room costs, and I think both of you mentioned, Freddie, you mentioned the emergency room efforts at Memorial Hermann to divert people from accessing care in the emergency room because that's a costly and inefficient way to access care and often is not needed, especially for the uninsured. Ted, you mentioned that that's also one of the goals, I believe, of the Texas way is to more efficiently utilize the emergency room resources and not to have the uninsured accessing primary care through our ERs. And I wondered if each of you could address some of the studies that we've seen. Particularly, there was the Oregon Medicaid study that showed that the Medicaid population there that was part of the lottery expansion that they did a few years ago were 40% more likely to access care through the emergency room than the group that was not on Medicaid that was studied, the control group, as well as evidence from other states that have tried versions of Medicaid expansion in the past and have seen that Medicaid expansion population end up going to the emergency room more often. So to me, there's a bit of a disconnect in how expanding coverage through Medicaid would reduce that ER use, and I wonder if both of you could just address that.
Sure. I'll address it by the fact is that if you're going to do straight expansion and Medicaid expansion under the ACA, that's probably the result that you'll get. Because there's no incentives to change it. And that's not what the Texas way is. The Texas way is not Medicaid expansion. It's using the free market commercial insurance to manage those claims. It's to provide somebody a doctor that they can go to, as opposed to having to go to the emergency room. I can tell you that in a couple states we've seen the effect of something that's in the managed care area, where we've not gone with a straight Medicaid expansion, where Medicaid utilization, uninsured utilization in the emergency room has dropped 35% in the last 6 months. Dropped 35%. That's what can happen if you do this right. If you just do straight Medicaid expansion, you're going to get what you said. Provide more benefits, they'll still show up wherever they want. Let's direct them to the right place. Get them to a doctor where they can go and actually see their physician on a timely basis. Let's find a better approach to providing care and a continuum of care. Let's not put them in the emergency room. Freddie?
Well, first, I just wanted to make a statement that I appreciated Byron sharing some information. Just wanted y'all to know that we had nothing to do with paying for the cost of his travel or lodging to be here today for his participation on the panel. John, I honestly have not seen the Oregon study, but let me speak to the way in which our system has addressed our ER. We looked at the fact that, again, let me start for the baseline, 65% of our admissions come through the ER. Last year we had about 3,000 of kind of the most egregious abusers, our most frequent flyers. Then we had a second tier below that was probably another several thousand who used some part of our emergency department multiple times. So we had a multiple-pronged strategy for approaching that. And the navigators, community health workers we've got sitting in our emergency departments are doing a much more effective job every single year at guiding these people not just away from the ER setting, but also actually providing, at the end of the day, it's kind of counseling. I say a lot of these folks are kind of, they've become de facto insurance agents, if you will. I mean, they're sitting down and getting these folks. We'll find out if they're eligible for the gold card at the hospital district in our community, help them become eligible for that. Help them sign up for subsidies under the ACA. Help them get enrolled in Medicaid. And it's not just a circumstance of helping them with paperwork when they're in the office and they walk away, and that's the last encounter we have with them. Where we have seen some success, and where across our system we've seen a reduction in those individuals' abuse of the ER, is that we basically help them establish a medical home, and we end up with a circumstance where we very often will have a nurse practitioner, we'll have a navigator, we'll have someone from our system following up with them. And a lot of it is, you get them not only invested in their own health decisions, but you also provide some, you basically have to help them, guide them to accountability for the way in which they're going to take care of themselves going forward. You've got a continuum of care, to Ted's point, created where one did not exist before, and where we have the ability, where we've been able to identify our most egregious abusers of the ER, you can see those folks come off of that list. So, you talked about getting granular, John, earlier. I can tell you that we're looking at our strategies aimed at the emergency room, or our emergency departments, and we're seeing some pretty significant positive outcomes from a lot of those strategies that have been deployed towards the ER. Thanks.
Yeah, absolutely, and thanks for the answer. Just to follow up, I wanted to come off your comment about about incentivizing proper use and providing disincentive for patients not to access ER for primary care and non-emergent conditions. And I wonder how you're looking forward to the possibility of trying to negotiate with CMS and the federal government. What sort of leverage do you think we might have where other states have failed? And this is a real question that I have, because we have an example just in the last year of Pennsylvania negotiating under its Healthy PA program for Medicaid expansion that utilized private coverage in the way that Ted described with the Texas way. One of the things that Pennsylvania wanted to do was increase the penalty for non-emergent access to the ER for people on Medicaid from $8 to $10, a $2 increase. And Utah wanted to do the same thing. CMS said no to both of those states as part of the negotiation of their Medicaid expansion waivers. And I wonder why we should expect something different when it comes to trying to incentivize accessing care in the right place for people on Medicaid.
Sure. And not to be push that, I guess it's okay. Not to be trite, but Utah and Arkansas and even Pennsylvania are relatively small states when it comes to the Medicaid population. Texas is the big plum that Washington wants. We have a lot more muscle, and we should negotiate hard for what we want. I'm not confident that we'll get everything we want by any means, but I think we've got a lot more leverage because we're Texas.
I don't think you are on, by the way.
Oh, I'm sorry, I couldn't.
Is Mike on?
Okay.
Freddie.
Well, I'd like to focus on, we touch very, very briefly on the waiver, but as it relates to the DSRIP projects for Southeast Texas and for Region 3, and the number of those, I think on percentage basis, if you looked at the direct impact on the emergency departments across the state, and then if you looked at the indirect impact, you'd have a significant percentage of our DSRIP projects for Region 3 that are really focused on these strategies. And to, John, to your question, I think that CMS, at the end of the day, approved, and I think for purposes of our semi-annual reporting of our results from our DSRIP projects, again, focused on the emergency departments, I think they were not only satisfied with the strategies that we've come up with, but I think based upon at least our initial responses to our semi-annual reporting of the successes of those projects for our region, I believe that they continue to be satisfied with what we're doing. I can't really speak to what's happening in the other states, though.
Okay, great.
I want to say one thing. I get a little skeptical about some of the stuff about ERs and EMTALA and all that sort of thing, because EMTALA is pretty specific. It says that if somebody's life is in danger, they have to be stabilized. You can actually transfer them to a different hospital once they're stabilized. It doesn't say you have to treat people with the sniffles. But every time I go to the emergency room, there are people there being seen with the sniffles. And I'm pretty sure a lot of them are low income. I don't know, but I'm pretty sure that's the case. So I get a little suspicious. I kind of see the ER as being a billing opportunity as much as anything else.
I promised I would open it up for questions, and I want to make sure that I do that. So do we have any questions? And I see in the front here, sir, we do.
Emergency rooms are such cost centers.
We have a mic here.
If emergency rooms are such cost centers, why do I see all these billboards advertising how short the wait time is, which would seem to encourage somebody to come to that emergency room? And the other thing is, do you have televisions in your emergency room?
In our reception areas? Actually, I think that I'm going quickly through our system. I think in a couple of them we do. I can't speak to every single one of them right now because I'm just trying to think of the last time I was in each one of them.
I think probably almost all, unless you're very, very
I really can't speak to that. I will say to your comment about the billboards, I would encourage you to distinguish between the freestanding ERs that are popping up just like dialysis centers on every block versus hospitals. Okay, good. And I mean, from a patient quality perspective, we're always going to be motivated by figuring out a way to bring down the average length of stay. We are consistently increasing our quality measurements and bringing our costs down. One of those survey results you can imagine is, did you feel like you were treated, you were seen in an appropriate period of time? Did you get in and out in an appropriate period of time? So I can see that people would want to market that, but I can also tell you that I don't know what part, forgive me, I don't know what part of the state you're from, but for the Houston area, we've probably got a billboard about every quarter mile from a freestanding ER saying, don't go to a hospital because we can see you right now. And that's kind of a different issue from what we're facing in our ERs. Okay, thanks for your question.
You may see that in Dallas, but you'll still on. You may see that in Dallas, but you'll also find that that's not done to attract the uninsured. And if you go to Parkland, you'll find that the waits are anywhere from 6 to 8 hours. It's not good medicine. And at Parkland, we try to get them in and out as fast as possible. But so measurements in terms of throughput in an emergency room are important. It also should be said, if you look at your Medicare reimbursements, you're now under a pay-for-performance model that says patient satisfaction is a huge part of it. And patient satisfaction is how long did I have to wait. So that's one of the things that they're looking for.
More questions? See the gentleman at the end here in the red sweater.
I've got the mic.
Oh, you have the mic. I didn't know it had been handed off already. If you have the mic, then you have the question.
I've got the mic. My question is this. I know we have very savvy people in the room, but I really want to make sure that a question about price is not skated over. My husband and I have owned and operated medical clinics in Texas for the last 30 years. And last year, my honey underwent hip surgery. So, of course, now our perspective is a little different. And I would really like to know what it is hospitals are doing specifically, if you two gentlemen can answer that question, about the patient leaving the hospital, the procedure there. Case in point, when we got our bill, there were medications on that bill that he did not actually receive. There were services on there that he did not actually receive. Now, mind you, my husband is a physician and I'm a medical professional. So if that happens to us, I cannot imagine what must happen to the general public. A $60,000 surgery, of a $60,000 plus bill that we got for the hip surgery, $1,500 of that was given to the surgeon. I don't think that most patients actually realize that, and I'm sure the general public doesn't realize that. So my question, again, has to do with the issue of price. When we took the bill to the people that were helping us to get out of the hospital, reviewing the bill, that type of thing, and we asked questions about, okay, what's this? He didn't get this. What do we do about that? He didn't get this. They didn't know what to do, because they had never had anyone challenge the bill.
Yeah. That is not a good result, and you should have people that can actually answer that question for you at any hospital. One of the challenges, though, is you look at what's happened in healthcare for the last 40 years, since Medicaid, Medicare was started, is Medicare requires a standard charge across all. Whoever shows up gets charged the same thing. And so then when Medicare started reducing their reimbursement, Medicaid sharply reduced theirs, and you had a huge increase in terms of uninsured care. what you ended up having, the problem is how do you do cost shifting? And so cost shifting was done through charges and back in the mechanisms. And so what you have today, and I would be the first to tell you that we're trying to do many things about it, is a charge master in a hospital that doesn't mean anything. It really doesn't mean anything. That doesn't mean that things should be on your bill that you didn't get. That's not appropriate. So California, for example, is taking an initiative right now to do what they've got a smart name for it. I don't remember what they call it, but in essence, what it is they're working with all of the payer plans, and so they're going to cut their charges in terms of like 50%. But that as long as it's neutral in terms of how they get paid. Because they've negotiated these deals over the years as a percentage of charges or something else. And so if we can get to a situation where we can actually have some, I say that in terms of anybody I talk to, hospitals are the only place in the world that charge you something they never expect to be paid. And it's because they were forced to do that under the regulatory environment that we have today. And we need to find a solution to it. One of the things that's happening as you move away from fee-for-service medicine and as we move into more at-risk or a capitated environment is that won't happen anymore. You'll be able to actually look at hospitals and health systems more in the terms of a cost center and not as a revenue center. And you'll be able to look at managing that cost. But we got to get away from Medicare's demand for a standard charge. It's driven this industry to have charges that are far exceeding. So if you're a person that wants to know what you're going to have to pay, which is what we really want to have happen, hospitals don't have that information. That's the problem. Is the information is all contained at the insurance companies. They know what your deductible was. They know how much of your deductible you got paid. They know what the deal they cut with the hospital or the surgeon or somebody else is. So we got to get transparency, and I think the health plans are willing to do that. But it's not going to, having somebody publish the top 10 charges in a hospital doesn't mean anything to you. So I'm not trying to delve with the charge issue. The fact that something's on your bill it shouldn't be, that's just inappropriate.
Let me respond to the question. We have our revenue cycle has got a patient billing office that you've got kind of a group at the front end and a group at the back end of the process. And as a system, what we've attempted to do by integrating kind of all the touch points within our system, whether that's from the 3,000 plus affiliated physicians within our system, we're teaching hospital for a University of Texas Medical School. As it relates to those affiliated physicians, the lab, the pharmacy, rehab, if that's a part of the course of treatment, we've tried to get, I think, a sensibleness to the billing process, but also a level of understanding to where you don't have the circumstance that you and your husband encountered. I'm not going to say that people don't question bills. That certainly occurs. And the way in which it occurs within our system, would be very surprised if a person confronted with a bill and asked a question would not be in a position to explain it, to answer the question satisfactorily. And to Ted's point of the access, the involvement of the insurance company in that process, once again, when I look at our patient billing folks, they are interacting on behalf of, and at the end of the day, very often advocating on behalf of our patient when it comes to trying to gain a better understanding of what they're receiving from an insurance company as opposed to what they're getting from our hospital upon discharge, and then follow up afterwards. We have seen, and again, I come back to the subject of patient satisfaction and some of the surveys that are occurring and are having to occur for all hospitals. One of the areas where we're seeing some improvement within our system is precisely there, where there are better opportunities for people to have all of the components of the care within our system on their bill, present in a bill and understood better than it's been historically. So, but thank you for your question.
I just wanted to say, if you read the Brill article, he mentions the charge master. He mentions interviewing senior people at hospitals, got no idea where it came from, what it is, its history, any number of things like that, which tells you right off the bat something's badly wrong. When people talk about today that the healthcare market is messed up, my first question is, what market? There is no such thing as a healthcare market. When consumers don't pay for something themselves, it's not a real market. And it's a highly distorted economic system. I'm not quite sure what you call it. It's not quite socialist. It's not, I don't know. As a technical term, fascist is pretty close, because it is, because it's a corporatist system. But that doesn't even really quite capture it. But what definitely is happening is patients are being well, they're sort of like in the public education system, where people who want to spend more money on public education all the time hide behind kids. The healthcare industry hides behind patients. And the problem is that when I was researching my paper that I did on healthcare, I found a statistic. It was something like 80% of all hospital bills had errors in them. And of course, they always seem to favor the hospital. When you see an error rate like that, it's not error. It's systematic fraud. And maybe it's, yeah, I can say yes, it's absolutely a result of the distortions of the system, of government being involved, with the tax system favoring benefits and us being paid with insurance instead of cash. All these things are involved, yes, and these people in the hospital system, the healthcare system in general, are just responding to incentives. I accept that. The incentives are all screwed up, but you don't fix it by just expanding on the current incentives. You change the paradigm. HSAs were a way of doing that, and are a way of doing that, and that's something that I'm very concerned might go away with Obamacare, but it's something that needs to be expanded, and it puts the consumer increasingly in the driver's seat. And yeah, I hold hospitals accountable. I didn't pay $2,500 for my kid's broken leg and no service. I paid way too much in the end, in my opinion, but I didn't pay that. And I have no doubt that the balance of what I didn't pay is on their bad debt balance, which is fake. So I'm not saying this to attack necessarily people in the healthcare system, because like I say, I know that they're responding to incentives. I just want the incentives changed. I want people to understand the incentives, and for Pete's sake, let's not use these excuses to expand an already really bad system. And by the way, where you should have gone to get the surgery is the surgical center in Oklahoma, where they give you upfront pricing and they don't take government handouts and insurance. I think ultimately, if the healthcare industry and individual physicians will increasingly turn to that, while it's still not illegal to do so, it would make the system far more efficient, far more effective and reasonable.
I want to get one more question in before we run out of time. We're already a little bit over, but I want to get one last question in here, sir.
I got the microphone.
Yeah, you got the microphone, you got the question.
David Hoyer, ER doctor from Houston. One important point that has not been made up to now about that was shown in the Oregon Medicaid expansion was that it did not improve the health of the recipients. So that's an important, you got to ask the question, well, why do it if it doesn't improve the health of the recipients? I am encouraged by the Texas way that was presented, in particular the emphasis on penalties for non-emergent ER usage. But I'm still skeptical that that this plan can actually be enacted. I'm concerned that we'll eventually cave and accept basically sugar-coated Obamacare Medicaid, which will increase ER usage, which will increase costs, and eventually there'll be more cost shifting and all the other negative things that we're trying to avoid.
Well, the Texas, I think what he's talking about, the model is an HMO Medicaid system, which is better than what Texas has been doing. Arizona's been doing the HMO Medicaid model since 1982, when Arizona finally signed up for Medicaid. It's still a major burden on Arizona's fiscal system. It still is an issue of constantly increasing costs. Everything here that was said today about the system and the problems in it exist in Arizona. There was a conservative group in Florida that was pushing an HMO model for Medicaid, and they were calling it the cure for Medicaid. It's not a cure for anything, because all the incentives, the negative incentives, are still there. It mitigates some of them, but it doesn't fix it. So, and there may be some ways to improve on the Arizona system. I have no doubt that there are some ways that could be done, but the incentives that I'm talking about, the issues that I'm talking about, aren't really mitigated significantly.
Yeah, I might just tell you that under the 1115 waiver, Texas is the most managed care managed Medicaid population in the country. And as a result, we're running about $2 billion a year less in terms of where we would have been on a fee-for-service model. So, yes, it can save money.
Want to join me in thanking our panelists this morning.